PTAs. I hope you guys are doing well. Today we will talk about other neurological disorders such as MS, ALS, Guillain-Barre, and several more. So we'll start with MS, multiple sclerosis. This is a chronic demyelinating disease. It's of the central nervous system. The myelin that surrounds a healthy nerve quickly allows you to quickly send nerve impulses, because remember, when there's myelin there, then the impulse can jump from node to node, and so it goes through a lot faster. When it's damaged, then the signal moves slowly and it becomes less intense. It's kind of like having a thermal mug that's insulated. If it's insulated well, then the heat stays in. If it's not insulated well, the heat escapes. Same with a nerve signal. The myelin is that insulation around the nerve, and if it's not well insulated, then some of the signal will be lost as it travels and it will slow down, kind of like with the electric wires that are wrapped in rubber or some type of insulation to keep the electrical signal strong all the way down the wire. With multiple sclerosis, there are plaques, which are, they're called sclerotic plaques, which is why it's called multiple sclerosis. They're scar-like lesions that form throughout the brain and the spinal cord. So this is a disorder of the upper motor neurons, and it commonly involves areas like the optic nerve, so it can cause vision problems, the periventricular white matter, the corticospinal tracts, posterior columns, and cerebral peduncles. So those plaques build up in the brain and cause changes in the brain and spinal cord to the way that the nerve impulses travel and to your movements. With the pathophysiology of MS, demyelination of the white matter occurs throughout the brain and spinal cord because of destruction of oligodendrocytes, which make up the myelin sheath around the axons. So as those oligodendrocytes are destroyed, the myelin is destroyed, and the axon is left unprotected. It's damaged. It can cause inflammation, which then leads to scar tissue and plaque formations, which also damage the impulse that's traveling through when there's scar tissue there. And cause more degeneration, and that's the sclerotic plaques, that scar tissue, that are a key indicator of multiple sclerosis. Clinical presentation: muscle weakness, abnormal sensation. Some of these are the paresthesias, which is that pins and needles sensation, or dysesthesias, which is a burning or an achy sensation. There's often visual changes, which is oftentimes the first thing that is noticed, is the vision changes. So graying or blurring of vision, diplopia, which is doubled vision, nystagmus, those jumpy, shaky eye movements, poor coordination, difficulty speaking or swallowing, scanning speech, which is a slow, long pause, thinking about the words really hard before you say them, not a fluid speech, fatigue, bowel and bladder problems, constipation, urinary retention, urinary frequency, are all signs of multiple sclerosis. There are various types of multiple sclerosis, and they're basically separated by the relapse periods and the remission periods. So the first is relapsing remitting MS. That's the most common, where there are periods of relapse where you're getting worse and periods of remission where you're getting better. So the relapse periods, the symptoms are worse, and then the recovery, the remission periods, you're able to recover and may get back to or close to your baseline of movement. As the disease progresses, the remission or recovery periods become shorter and shorter, and the exacerbations become more and more frequent. With primary progressive, which is a rare type, then you are constantly progressing, constantly getting worse without those recovery periods. With secondary progressive, you start out with that relapsing remitting type of MS, and then as time goes by, those relapses come more often and last longer, and those remission periods just aren't enough to recover. And so there's a steady decline in the overall health because of the lack of recovery periods and the frequency of relapsing periods. And then with progressive relapsing, it's basically the same thing, but there are a few recovery periods here and there, but they're just not long enough to allow you to recover to the point where you go back to your baseline. So you're progressively getting worse. Typically, MS is diagnosed by an MRI. It can show those sclerotic plaques forming in the brain. So those white dots on the MRI vision. As far as medications, some medications can be given to decrease the frequency and the severity of those exacerbation periods. As far as a PT treatment, we can do some strengthening, always at a submaximal heart rate, so less than 85%. You do not want to over fatigue, and most of your treatment is during those recovery periods, not during the exacerbations. Okay, so we're not doing active PT when they're in an exacerbation or a relapse, but when they're in the recovery periods. Manual stretching before the exercise to prepare the patient is good, holding those stretches 30 to 60 seconds. Some of the areas that typically are tight and need to be stretched are the hamstrings, the neck muscles, the heel cord, also known as the Achilles tendon. Weight belts can be used during gait. It could increase proprioception and trunk control. You just have to be careful about having the patient practice functional mobility or functional task with weights on. Ideally, if you are using resistance, it's more proximal than distal, because sometimes what will happen is if they're practicing with resistance, then once they take that resistance off, they'll overshoot. So let's say you're having them walk with ankle braces on. Not a good idea with this population. Then you take them off and their walking is more abnormal versus more normalized. So just be cautious about, resistance training distally for reasons like that. And you do not want to over exacerbate somebody with any type of neurological, especially a progressive neurological disorder, because it's really hard for them to recover. So not overworking. Next, we're talking about ALS, or amyotrophic lateral sclerosis. It's also known as Lou Gehrig's disease. It's a terminal progressive disease involving degeneration of the upper motor neurons and the lower motor neurons. So whereas MS is only the brain and spinal cord, upper motor neurons only, this is all the upper motor neurons and lower. So it's the peripheral nerves, it's the cranial nerves, and the brain and spinal cord. This attacks your voluntary muscles. It leads to death eventually due to respiratory failure, or other complications with like aspiration pneumonia, choking on things. And most patients who are diagnosed with ALS will pass away within 3 to 5 years of their symptoms starting. So it is terminal, there is no cure, and it is a very quick progressive disorder. Some of the clinical presentation include muscle weakness, stiffness, cramping, atrophy, muscle wasting, fasciculations, which is the twitches, difficulty swallowing and speaking, fatigue. You'll often see distal symptoms before you see the proximal. So most commonly, you'll see symptoms in the hands and the arm before you see them in the face and tongue. You may or may not have cognitive deficits like dementia associated, and then the sensation is typically intact. So it's just motor function that's being attacked, not sensation. You must have upper motor neuron and lower motor neurons in at least 3 of the domains in order to get diagnosed with ALS. The domains include the bulbar domain, cervical, thoracic, and lumbosacral. At least 3 of those domains must be affected for it to be a definitive diagnosis of ALS. The only medication currently that I'm aware of that they use to treat the progression and slow down the progression of ALS is the Riluzole. There's probably some off-brand names and things, but all the other drugs are just treating the symptoms. I imagine that there's probably more drugs than this at this point, but that's just the only one that I'm aware of that I have seen used in clinics to slow down the progression. Treatment, so in the early stages, you want to avoid heavy eccentric exercises. It's harder to recover from those, so you have to be a little more careful with that. If they have at least a 3 out of 5 muscle grade in a muscle, then you can use some resistance. They say that in muscles that have at least a 3 out of 5 muscle grade, that overuse is not a big concern. However, I'm still cautious with anybody with any progressive neurological disorder. I try not to overly fatigue anybody because it's really hard for them to recover. In later stages, you're mainly supporting the weak muscles, working on breathing exercises, working on environmental adaptation so that they're able to maintain some level of independence with their functional mobility, caregiver training, balance training. You're allowing for more recovery times, and I would not do during those times. Okay. Hopefully everything's good. I just got a weird message saying I was kicked out for a minute, so hopefully we're good. All right, Guillain-Barre Syndrome, GBS. It is a broad group of demyelinating inflammatory polyradiculoneuropathies. It is a disorder of the lower motor neurons, so the peripheral nerves, the nerve roots, the cranial nerves, but it does not affect the brain or spinal cord, only the peripheral or the lower motor neurons. And it results in flaccid paralysis. So remember, one of the common signs when you have an upper motor neuron disorder can be spasticity. And if it's lower motor neuron, it is often flaccid muscles. The symptoms typically begin distally and progress proximally. There are two major subcategories, the AIDP and AMAN. The AMAN is purely motor, but it can progress and attack the respiratory muscles, which could cause respiratory failure. Typically, Guillain-Barre syndrome, it's an autoimmune response that attacks the nerves. What triggers it is unclear, different in every case. So sometimes it's an infection. Sometimes it is a really stressful event. Recently with COVID, the Johnson & Johnson COVID vaccine was recalled because of the amount of incidents where people got Guillain-Barre syndrome or blood clots associated with, recently having that shot. But it's also often thought to be triggered by a virus or a surgical procedure or some type of vaccine, so some type of big medical event. Demyelination and inflammation leads to slow and blocked nerve conduction. Once that process subsides, the Schwann cells can regenerate and they can remyelinate and recover. The time frame between demyelination and the beginning process of remyelination is typically at least 2 to 3 weeks, and Guillain-Barre is one of the most common causes of acute paralysis. One of the major concerns with Guillain-Barre is the muscle weakness that affects their respiratory muscles, which then can make it life-threatening. So most people with Guillain-Barre will be hospitalized. Some may even at some point be placed on a ventilator because of respiratory muscle failure. The presentation, distal paresthesias or hypersensitivity in the toes, weakness throughout the limbs, the diaphragm, the breathing muscles, autonomic nervous system symptoms like fluctuating blood pressure, poor venous return or blood pooling, tachycardia, arrhythmias, myalgia, that's muscle pain that might be related to spontaneous firing of a demyelinated nerve, just constantly giving the brain a signal something's wrong, which it then interprets as pain. Difficulty speaking, which is dysarthria, difficulty swallowing, which is dysphagia, facial weakness or diplopia, the double vision, areflexia, absence of the deep tendon reflexes. Acute, the symptoms appear and progress. This is typically about a 4-week period of time. So typically It comes on quickly and progresses and gets worse within the first 4 weeks. Then the symptoms plateau and are no longer getting worse. This can last up to 4 weeks, in addition to the acute period. And then the recovery period typically is when you're starting to regenerate and recover and improve. So it may take up to a year in some patients. Some may be left with residual deficits such as weakness or paresthesias, and some never fully recover. So some make a full recovery and others do not. Some of the treatment considerations during the acute phase, your main goal is to minimize the symptoms, to support the breathing, prevent secondary conditions like skin breakdown or contractures, manage the patient's pain. Oftentimes they're in the ICU during the acute phase because of the diaphragm being affected, causing them to have trouble breathing. During the plateau phase, the goal is focusing on acclimating to upright, being able to sit up without that orthostatic hypotension, that drop in blood pressure, maintaining the range of motion so that they're not losing motion or losing the ability to gain that function as they improve, improving their breathing, their pulmonary function, avoiding overfatigue, overexertion. And then once they reach a recovery period, then you can start doing strengthening and functional mobility, just like other types of physical therapy. Again, I would be very cautious and careful not to overexert, but you can progressively begin doing more and more. Some of the Binsman's recommendation is to use short periods of non-fatiguing exercises matched to that patient's strength. Increase the difficulty of that activity level only if the patient improves or if there's no deterioration in status after a week. I actually use that with almost all my patients. If I progress them in something, I wait at least a week to see how they respond to that change in demand on their body before I progress them again, because delayed onset muscle soreness typically occurs 1 to 5 days after an exercise. So if the very next day they're not sore and then I up the exercise more, I haven't actually given them time to demonstrate any or display any delayed onset muscle soreness to truly know how their body responded. Return patients to bed rest if they start to decrease their strength or function. If you see a big decline, then they're probably doing too much and they need to be on bed rest again. Direct the strengthening exercises at improving function, not just improving strength. Function is going to be the forefront of your brain and the top priority of the goals for every neurological patient, period. Other treatment considerations, you never want to overwork a partially denervated muscle, period, regardless of what disease process they have, because it really struggles to recover. So you can focus on muscle strength and on muscle endurance, but you do not want to overwork. Some of the signs of overworking are delayed onset muscle soreness. So if the symptoms get worse and they're more sore 1 to 5 days after the exercise, and they're not able to do the same amount, generate the same amount of force, like a 1 rep max, which we typically don't go that specific into just, okay, now you're really sore, let me see how much you can lift. We don't, but that is one of the signs. You want to start with low repetitions and short, frequent bouts of exercise, and then progress from there. Make sure to include endurance training in your home exercise program in order to increase muscle endurance, as that is one of the main goals in patients like this. We're not worried as much about increasing strength, but endurance and function. Post-polio syndrome. So poliomyelitis is a virus that results in neuropathy leading to motor impairments. The virus was somewhat eradicated in the United States with the polio vaccine. However, in some parts of the world, some of the symptoms and some of the prevalence of the virus is returning, maybe because of a lack of vaccinations or maybe because of the availability, but It is a lower motor neuron pathology. It affects the anterior horn. After polio, the surviving axons should be able to increase their size and their innervation so that they are able to innervate a denervated muscle. So basically, other axons take over and account for the muscles that are no longer getting that message. And so one axon may create more nerve endings to innervate a larger area. But if they're unable to either reinnervate or to reach those muscles, then post-polio syndrome occurs, where the muscle is just not being innervated by the nerve, and so the motor response is not able to happen. It's a denervated muscle, meaning it's not getting the message from the nerves. Some of the symptoms are slow progressive weakness, muscle atrophy, fatigue, pain, difficulty swallowing, and cold intolerance. Significant atrophy is often the case, like in the picture. With physical therapy, most of the time what we are focusing on is actually independence with functional mobility. We may include some bracing on the weak side, some exercises to strengthen the muscle if there is some input being received by the muscle, adaptive equipment, and just increasing independence and function. Next is myasthenia gravis. This is an autoimmune disease that results in a defect in nerve impulses transmitted at the neuromuscular junction. Antibodies actually block or destroy these receptors that are needed for acetylcholine reuptake, and that prevents the muscles from being able to contract. It's associated with a enlarged thymus, and it is often associated with other diseases like lupus, rheumatoid arthritis, diabetes, and there are multiple, forms of myasthenia gravis that range from very mild to very severe. It's similar to MS, where it attacks different muscle groups at different times and leaves with some level of destruction. However, the recovery is not as prevalent as with MS, that the muscle groups that have been destroyed don't typically return to their baseline, even in periods of recovery or remission. Some of the symptoms are extreme fatigability, fluctuating muscle weakness. Ocular muscles are typically affected first, just like with MS. It can cause that diplopia, which is double vision, or the ptosis, which is the drooping of the eyelid. Dysphagia, dysarthria, cranial nerve involvement are all common, and then they typically do have remission and exacerbation episodes, just like MS, where there's periods where it's worse and periods where it's improving some. As far as myasthenia gravis crisis, this is when it has attacked the respiratory muscles and it creates a medical emergency and often requires a patient to be placed on a ventilator in order to save their life. So that is a myasthenia gravis crisis if it's attacking respiratory muscles. What do we do with PT for someone with myasthenia gravis? We typically do some type of respiratory training, pulmonary interventions, energy conservation techniques, maybe some gentle strengthening, mainly focusing on isometrics and preventing osteoporosis. One of the common side effects of the medications that are taken for myasthenia gravis is osteoporosis. So in order to prevent that, weight bearing is really important to reuptake that calcium that's being lost to prevent that disease. So weight bearing activities are huge in PT for myasthenia gravis. Polyneuropathy, this is caused by a disease that affects multiple peripheral nerves. Sensory impairments are in a stocking glove distribution. They typically start in the feet and then progress upward or proximally, leading to the hands, necks, and then up the legs. Sensation impairments, but also some weakness and some atrophy in those areas. Again, it affects distally more so than proximally. They may have some fasciculations, those twitches. They may have decreased deep tendon reflexes. One of the most common polyneuropathies that a lot of us are aware of is the diabetic peripheral polyneuropathy. Symptoms are typically symmetrical, so it's not worse on one side than the other, and an EMG can be used in order to determine the extent of the nerve damage. Trigeminal neuralgia, this is actually common in people who have multiple sclerosis. It's caused by abnormal pressure or irritation of the trigeminal nerve. It causes unilateral symptoms because it's only one nerve that's being affected typically. And the symptoms are primarily related to sensation or pain. So sudden sharp shooting pains, a jolting pain, shock-like pain, persistent aching or burning sensations. Those are the main things that patients complain of with trigeminal neuralgia. The diagnosis is primarily just based on symptoms, not a lot of testing done. And the pain may be constant or it could be episodic, where it comes and go, especially with activities of daily living like shaving, chewing, brushing teeth. Some of those things will cause inflammation in that area, which leads to the pain and trigger an episode. They can actually use an MRI to track the blood flow near the trigeminal nerve to determine if it is leading to some of the symptoms. But again, that's not a way that they typically definitively diagnose. That's just if they're trying to figure out the cause of the symptoms and do some medical management towards that. Remember, trigeminal nerve is the cranial nerve 5, and that's the one that's being affected here. Bell's palsy, this is an acute onset of sensory and motor deficits in structures that are supplied by the facial nerve. It affects the muscles associated with facial expressions, with saliva, with tear production. Most patients display spontaneous recovery within weeks or months of onset. It is often related to a recent virus or high stress event that will cause it to start. And like I said, it typically spontaneously recovers. So it's difficult for the patient to close their eyes. I had a friend in college who had Bell's palsy after she had some type of a virus, and she couldn't close her eyes, and they didn't water very much. And so it was constantly dry. So she had to start wearing an eye patch. Interestingly enough, it was like October, and so people thought she was like dressing up. So a lot of people would be like, "Arg," when they saw her, and she's like, so embarrassing. She also met her husband while she had Bell's palsy, and their first kiss, half of her mouth didn't work, which is kind of fun. But that whole side of your face basically does not work. You're not able to do facial expressions on side. The eye droops, the lip droops, and even the tongue has difficulty some on that side. So those are our other neurological disorders for today. I hope you've enjoyed, and I'll see you next time.